All right. Give people a second to find their seats. I love it. I hate to cut off the family reunion. I'm just like, look at this. It's so nice. Hugs, hugs, hugs. Julia, I hate rushing that. It's like the best part of this lecture is this family. And my heart is just so full watching everyone get together. I just feel so lucky to be part of it. Thank you all for being here. And where's Mom? There's Mom. All right. Hello, everyone. My name is David Hackham. I'm the Pediatric Surgeon in Chief and co-director of the Johns Hopkins Children's Center. It's an absolute pleasure to welcome you to our fourth annual Haller Lecture in honor of Dr. Alex J. Haller. This event has become a cherished feature on our academic calendar. It's a great honor to see you all here today. Many of you are back here in attendance for the fourth time, and we feel so lucky to know that this event has become part of the Haller family annual tradition, just as it has become part of our pediatric surgery family annual tradition. This shows clearly that the Haller name is intertwined with that of Johns Hopkins Pediatric Surgery, which was the original intent when Dr. Julia Haller envisioned this lectureship. And I have to believe that Alex is looking down from us now and with warmth in his heart, seeing how this is developing. Before I bring Julia to the podium, please let me share a very warm welcome to Dr. Emily Haller, who is here today. We're so happy. And we're just so happy we can honor your dear husband's memory in this way. For those that don't know, and this is for the non-family members, I guess, Dr. Emily Haller is a pioneer in the field of gyne-obs here at Hopkins, and she served on the faculty from 1951 to 1997. It's so wonderful to see you. Please let me now introduce Dr. Julia Haller. And Julia is the ophthalmologist in chief at Wills Eye Hospital. And Julia really established this memorial lectureship in her father's memory to honor his immense contributions to pediatric surgery. For those that don't know, Dr. Julia Haller is an innovative retina surgeon scientist. She has innovated translational advances against blindness on many fronts. A brief bio, and this is so Baltimore, because everyone puts their high school first. It's so Baltimore. Julia was born in Baltimore, and this proves it. She was educated at the Bryn Mawr School. And they're very proud. There we are. There we are. Yeah. And oh, by the way, then she went to Princeton, and then she went to Harvard Medical School. But really, it's the Bryn Mawr. And then she went on to do her training in ophthalmology and a retina fellowship at the Wilmer Eye Institute, right here at Johns Hopkins, where, and I'm so proud to be able to say this year after year, she served as the first female chief resident at the Wilmer, just a note. Amongst Julia's many awards, over 400 publications and counting, as I checked, and tremendous contributions to the field, Julia is probably most proud, along with her husband, Dr. John Gotch, John, who is himself the Margaret Mosher Professor of Ophthalmology at Hopkins, most proud of their 5 children. And I know they can't be here today, but I did want to call them out: John, Natalie, Will, Alex, and Claire. Please join me in welcoming and thanking Dr. Julia Haller. Absolutely.
Thank you so much. It's such an honor to be here, and it's so wonderful to see so many of you all here in the audience. Let's see, slide next. Okay, great. Thank you. Thank you. There's Mom and Dad. So it's such a thrill to be here. And I really want to thank Dr. Hackham so much for picking the best lecturers in the world to give this. I really think it's a curated group that is just so amazing. And also the team, Rachel and Jen, and thank you all so much for all of the, feel like you put love into it in addition to all the hard work. We're very honored to have here Dr. John Cameron, who worked with my dad, and Mr. Ron Peterson, who also worked so hard with my father. There's so many people, still at Hopkins and in the Hopkins family who were part of that. And we're also very honored to have Dr. Kurt Newman, who was the inaugural Haller lecturer, in addition to being my intern when I was a medical student. There's so many friends and relatives here, and we already introduced my mom. And why can't I work there we go. And there are also, my siblings are here and my niece, and I just wanted to introduce those. We grew up so proud of our dad, who it's been 7.5 years now since we lost him. Here's the picture from the Hopkins publication that's so typical of dad with his big smile. My sister Claire is here. My brother Lecky, who's J. Alexander Haller III, with his wife Chapman and his daughter Madeline. Madeline is the only member of the next generation and she's standing in for all her the 16 grandchildren. Thank you. Bragging that she's on the dean's list at Auburn. And then my youngest brother, Fritz, right here with a bunch of his buddies from school. And we're all just so honored to be here with you all celebrating. We grew up hearing all the stories of everything that was happening at the hospital. We learned about the birth and evolution of children's surgery at Johns Hopkins Hospital. And we can quote chapter and verse all of the things that Dad was so proud of, including starting the first pediatric surgery division in a general academic medical center in the United States. And that was in 1963. And graduating his first specialty trained pediatric surgeon in 1965, which is a jaw-dropping 60 years ago. So it's very long. It's amazing to look back on that history. We knew about the Haller Index in pectus excavatum, which is still used, measuring on CT the diameter versus the width of the malformed chests. And we also heard so much about the burgeoning specialty of ethics in medicine, which was really in its infancy there. And there were a number of issues that came up that maybe we could talk about at dinner and things that Dad was involved with. And he was particularly interested in the holistic care of the patient and their family and making the hospital experience as wonderful as it could be. And he was also very involved in working on spiritual care and the Department of Chaplaincy here at the hospital, in addition to what he's probably most famous for, which is pioneering pediatric trauma care with the Children's Trauma Unit in the Park Building, collaborating with Dr. Cowley on the EMS system, and then establishing Hopkins as the Children's Shock Trauma Center and developing the Pediatric Advanced Life Support System, which he taught all over the world. And as kids, we would hear about the children coming into the emergency room and how it wasn't right for them to be next to an adult gunshot victim, with their skating injury. They should be in a separate emergency room, and indeed they were. Here we are last year with my mom, and some kind person brought over a picture of my dad. So we were all together again at this wonderful event last year. Here are a few of the other 16, and I would highlight my niece Alice Hughes, who's on the Hopkins faculty. So this is third generation of surgery at Hopkins, and she's on the orthopedic service. I see Dr. Riley, yes, and does trauma and is about to have her third baby and just got out of the operating room, and I hope she's got her feet up, and because my sister's here and ready to go to the hospital when the baby comes. Here's another picture of a few more of them at a party. And here's Mom and Dad. They bleed Hopkins blue and they love the Blue Jays. And here they are at a lacrosse game with young Alex, named after Dad, and Claire, and their Mom and Dad's rescue grand puppy. Mom and Dad dance through life together. And our hope with this event is that not only do we honor Dad's academic and medical contributions, but also the sense of joy and collegiality and enthusiasm with which he infused his life at Hopkins, and which we hope to help keep alive forever. Thank you.
Thank you so much. It's so warm. One of the great joys of my job is to pick the Haller Lecturer each year, thanks to the generosity of the Haller family. And to do so, as Julia mentioned, I look for a leader in pediatric surgery who has made broad and impactful contributions to the field, is a true trailblazer. And when I envisaged the speaker for this year's lecture, I could think of no one more impactful in multiple spheres of pediatric surgery than Dr. Mary Fallat. And I was so pleased when Dr. Fallat accepted. Dr. Fallat is professor of surgery at the University of Louisville and an attending pediatric surgery at Norton Children's Hospital, where she's been in practice for over 35 years. She's the former surgeon-in-chief. There's probably nothing better than being a former surgeon-in-chief at Norton Children's Hospital and division director of pediatric surgery. She's a champion, as you'll hear, of pediatric readiness of trauma systems, including all emergency departments that care for children. Dr. Fallat has a history of service and leadership in pediatric surgery and pediatric trauma. She's the immediate past first vice president of the American College of Surgeons and focused on visiting rural ACS chapters. Dr. Fallat has been funded by the Health Resources and Services Administration as a program director for the Kentucky Emergency Medical Services for Children program since 2004. She serves as trauma advisor to the National Pediatric Readiness Program, is a sub-principal investigator for the Trauma Burn Hub at Norton Children's for an awarded HRSA grant to develop a national pediatric pandemic network. But more than that, Dr. Fallat is a lead reviewer of the Children's Surgical Verification Program of the American College of Surgeons, and that's where I really got to know Dr. Fallat. So the Children's Surgical Verification Program seeks to provide quantifiable metrics for safe pediatric surgery across the country. And we were honored to host Mary and her team at Hopkins in January, where she assessed our entire pediatric surgical enterprise. And importantly, Mary really demonstrated herself to be a partner and a colleague in this process. And through this process, it became crystal clear to me what actually defines leadership in pediatric surgery. It's not volume or titles or even the number of committees we've all somehow agreed to serve on. It's the ability to walk into a room and make the people around you better without ever having to say so. And that is what Mary did and what Mary does. She's been a mentor to many of us in this room and many of our colleagues around the country. And so it's a great honor and a pleasure to introduce Dr. Mary Fallat to the podium as this year's J. Alex Haller Lecturer.
Well, welcome, everyone. Having a lecture at this time of day can be sleepy, so I'm going to try to keep it lively. And I'm going to actually start with a personal parable when we find my slides. There we go. So try that. There we go. Just a few things first. I decided to talk about pediatric trauma care because it is something that I've devoted my career to, as well as thinking in the future about system development. And I know that that was very important to Dr. Haller. And I do receive grant support, as was mentioned, for Kentucky EMS for Children, as well as for the Pediatric Pandemic Network, both of which I'm grateful for are still funded. But every day I wait to see if that's going to be maintained or not. Is it not? It's not advancing. Okay. Because this wasn't working. Did you push the little? Okay. Okay. I'm glad this isn't me trying to do this.
You're starting.
I'm sharing.
Just sharing.
Yeah. Sorry, Mary.
That's all right.
We don't actually. Yeah, we just saw that. You just moved over. So it's the window. If you look behind, you just had it. You look behind it. See that?
Okay, I see, I see.
So it's just a different screen. So now, yes, and just move that over. Yes. Yeah, and then make that yes. Yes, but no. You gotta.
Yep, there we go. I'm so sorry.
Okay. All right, you heard that. So I can't see it though. That's all right. Stand here. So the first thing we're going to talk about is my personal parable, which is 6 degrees of separation. I can tell that there's at least a few of you in the audience who will remember this movie. But it's the theory that everyone on Earth is connected to anyone else through a chain of no more than 6 acquaintances or friends of friends, highlighting the interconnectedness of people in a small world. So I'm going to start with Wilder Penfield. Wilder Penfield was a brilliant neurosurgeon. He was Canadian. He went to medical school here, as you can see. He was a mentee of Sir William Osler. For those of you who did their neurosurgery rotation, you will recognize the Penfield instrument that has helped to prevent brain scars during brain surgery. But he was a career neurosurgeon at McGill University, where he started a neurosurgical institute and was in the running for a Nobel Prize. He was a Rhodes Scholar. He had 4 children. His youngest son was named Amos Jefferson Penfield, also went to Johns Hopkins Medical School. He served during the Korean War, and he subsequently practiced OB/GYN for 30 plus years, ending his career in Syracuse, New York, which coincidentally is where I went to medical school. He was married and had 3 children, including David Jefferson Penfield, who went to medical school in Syracuse and was my boyfriend for 2 years. Dr. Haller was an undergraduate at Vanderbilt. He met his wife, Emily, at Vanderbilt. She graduated in 1947 from Vanderbilt Medical School. He graduated from Hopkins Medical School in 1951, went to Zurich, where he did an internship in pathology, and then spent 2 years in the military in Korea. He did his residency at Hopkins. Then he began teaching at the University of Louisville, where I was a resident and have practiced my entire career. But of course, in 1959, I was 6, so I didn't know him then. And I also didn't know that I would become a pediatric surgeon or that I would get to know Dr. Haller. He served as chief of cardiac surgery at Louisville General before he was recruited to come back here as assistant professor, where he led the new pediatric surgery division. And importantly, Emily, in her own right, went to Vanderbilt Medical School. She became an obstetrician and gynecologist. She did high-risk OB. And there were several articles written about her that I found, including, I believe, one by Julia, that talks about how she had 4 children in 4 years and 4 months. And she also stopped her career for 21 years to be able to take care of her children. And then she went back and did her internship, which is really fabulous. I met her in 1976. So the Penfields invited me and David to dinner where they were hosting the Hallers. And I can't remember if Dr. Penfield was a colleague of Dr. Alex Haller or Dr. Emily Haller, because Emily and Alex both did gynecology and obstetrics, but they also had in common that they were all at Hopkins. But long story short, at that point, I knew I wanted to be a surgeon. I did not know I wanted to be a pediatric surgeon until a few years later. I didn't marry David Penfield, or I wouldn't be standing here because my life would be different. But it was the second time in my boyfriend career that parents told me I was the wrong religion. So there you go. And so I moved on. I became a pediatric surgeon. I went to Louisville. I trained in Washington, D.C. There's my senior fellow, Kurt Newman. So we're good friends. And so the 6 degrees of separation also led me to think about 6 reasons that I should talk about trauma and trauma system development. All of these connections. And the last one is that Dr. Haller was the first pediatric surgeon to give the Scudder oration at the American College of Surgeons. And I was the second pediatric surgeon to give it. And we both were involved in pediatric trauma and pediatric trauma system development. So I thought I would talk about what's changed. I've studied his lecture. It was given in 1994, 31 years ago. And what would he be proud of and what would he be disappointed in? So he talked in his introduction about military and civilian inner-city battlefields as predecessors of trauma systems. And he talked about ATLS as the single most important contribution to the care of injured children and adults. We'll expand on that a little bit. And I will tell you that in 30 minutes, this will be snippets of both his lecture and my lecture, and then looking at advances in pediatric trauma care or lack thereof as we've gone through history. So in the 1940s and 50s, there was much trauma experience that came from the military experience. And there was an early call for military to civilian translation, which is really something that's a hot topic today. The other thing that was happening is that the EMS services were really still vestigial at that point. Hearses carried patients to hospitals. And the military transport experience was something that we thought we could learn from in trauma care. I thought this was interesting. Will Rogers, who was prophetic in the 1920s, said you can't say civilization isn't advancing. In every war, they will kill you in a new way. So here are some of the earlier wars, but I circled one of the things that I thought was, again, most important and most talked about today as something that can really save lives and decrease the mortality in trauma care. There were a lot of other things: wound treatment, shock treatment, triage and transport, MASH units, combat surgery, hospitals, forward surgical teams. All were advances as we went through different wars that really started to improve the mortality among our troops. But about 10 years ago, there was an intense effort to look at military-civilian integration and what that might mean for preventable deaths after injury, recognizing that what people die from early on is bleeding, uncontrolled bleeding. And so this has been something that is talked about in military circles and now civilian circles. We're trying to create a system of care that will better take care of our citizens by learning from the military. But perhaps one of the things that is missing, and has always been missing, is that children are excluded. Why? Children don't go to war. However, they are the secondary victims of war. They often show up overseas in combat casualty environments, and whether or not they're let in depends on who's guarding the military hospital. But there is a call for more training for our military to learn how to take care of children because this is something that hasn't been done in the past. Hemorrhage control, as I mentioned, has been recognized as the cause of early deaths after trauma. Stop the Bleed, some of you may have heard of the Stop the Bleed program, was something that was a response to civilian firearm injuries, Sandy Hook, to be clear. It's become a massive program. It's now global. We sent Stop the Bleed kits to the Ukraine to help them and also taught them how to use them. EMS services around the country are starting to give blood in the field as they recognize that not only stopping the blood flow, but also helping to resuscitate the patient by giving blood can hopefully interrupt that early cycle that leads to death. And the newest ATLS course has actually incorporated X at the beginning of ABCDE, and the X is for hemorrhage control. Probably not quite as important in children outside of penetrating injuries, but is something that is a new change in the ATLS course that's being rolled out. So the ATLS course started in 1980. I'm going to tell you a little bit about how that started. Pediatrics was not added until 1983 when Dr. Haller and his colleagues recognized that children are not small adults, that there were differences and we needed to take those into consideration. And he also mentioned in his report that there were two errors in judgment: the need to work in teams. So surgeons have traditionally worked in silos, and we needed to change that, especially for pediatric care, and forgetting about prevention, which wasn't really included in the early studies. So the causes of death in children in 1965, which was when Dr. Haller started to think about this, you can see accidents is what was listed in his report. We are getting away from the word accidents, recognizing that most pediatric deaths and injuries are unintentional. They're not something that are accidental. But in 1994, trauma was still the #1 cause of death. And sadly, it's still the #1 cause of death. If you look at this graph going from 2000 to 2020, over 20 years, the top line is motor vehicle crashes, and the bottom, the line right next to that is firearm injuries. Sadly, firearm-related injuries now surpass motor vehicle crashes as the leading cause of death in children in this country. Unfortunately, the truth is that that's getting worse. However, safety milestones have probably accounted for some of that decrease that you saw in motor vehicle crash fatality. We've had a lot of advances in statutes, so state laws have a lot better impact than good intentions. And so things like seatbelts, child safety seats, helping parents learn how to use their child safety seats, airbags, graduated driving laws, raising the age at which you can drink alcohol, safety programs like Safe Kids, gun locks, firearm lock boxes, medication lock boxes. These are all things that help to make our world safer for children. So in 1990, in 1994, in the first Scudder, there were two quotes. One was that in 1990, over 12,000 Americans died as a result of handgun injuries. In 2023, 47,000 Americans died as a result of firearm injuries, and 2,566 were children under 18. In 1988, Dr. Haller wrote that approximately 138,000 Americans were shot by children under 6 years of age. When I looked recently, it said in 2023, there were over 400 unintentional shooting incidents by children in the United States, which seems to me to be under what I would expect. But the websites right now are not completely up to date, but I think that's probably greater. So in terms of prevention, there are pediatric surgeons who really are at the head of the class. One is Barbara Barlow. She helped New York State pass a law that mandated that windows be barred so children would no longer fall out of windows. And that was called Children Can't Fly. And Marty Eichelberger, who helped train Kurt and I, was responsible for the Safe Kids program, initially called Safe Kids Are No Accident. They got rid of the accident part. And it's now a global program. Marty's won several awards for his concept that prevention can really help prevent deaths in children. And it includes not just trauma, but all aspects of pediatric care. Another place where we have made advances is in burns. So it used to be that house fires accounted for about a quarter of the deaths of children in this country. But now with fire alarms, smoke alarms, as well as fire retardant clothing and other safety measures, scald burns are really the most common reason that children get burned. And because of advances in burn care, only 3% of people any age with burns in this country die from their injuries now. So there have been a lot of advances in burn care. So Dr. Haller said, and I quote, "Should pediatricians be involved in the management of children with serious injuries? Injury prevention and control came out of a pediatric background since pediatrics focuses on preventing illness." So I think he recognized long ago that prevention was really important. I'm just going to go through a few of the programs that he was involved in and an evolution of care that included children, at least peripherally, but have made our country more safer for pediatric care. So the first was ATLS, Advanced Trauma Life Support. And although it did not initially include a pediatrics chapter, Dr. Jim Steiner started the program because of what happened to him, his family, and his children. He was on the way back from a wedding, and his plane crashed in a cornfield. His wife was thrown out of the plane, and she died in the field. His children, who were 10, 8, 7, and 3 at the time, were all injured. A few of them had brain injuries. He managed to get out of the plane and walk to the road. He was picked up by a Good Samaritan. They went back and got the 4 children, and they went to the closest rural hospital, and the door was closed. They banged on it. A nurse came to the door. They managed to get a couple of the community doctors in to help, but they really didn't know how to help these children. And so Dr. Steiner, who was able to get his family airlifted the next day to Nebraska, where they lived, said, "When I can provide better care in the field with limited resources than my children and I received at the primary facility, there's something wrong with the system, and the system has to be changed." He was an orthopedic surgeon, but what I love that he said, you have to train them before you can blame them, because, prophetically, really, we can't criticize people who don't have the fundamental knowledge that we need. We need to teach them that knowledge. Another great story is how the Federal Emergency Medical Services for Children program started. It was at the behest of Calvin Sia, who was a pediatrician in Hawaii, and he urged the American Academy of Pediatrics to develop EMS programs to decrease disability and death in children. The EMS system, federally funded, had been started in 1973, and true to form, it excluded pediatric interests. And so he and his colleagues were pleading with the government to try to develop a system that was inclusive of children. After he introduced this, his aide in Hawaii had a daughter who got meningitis, and she received very poor care, and she died. And so he was able to recruit a few other individuals, Orrin Hatch and Lower Weichler, to introduce EMSC legislation, which is ultimately passed. Dr. Haller was part of a conference in 1988 called the Ross Conference. Ross was a formula company, and every year they had a pediatrics conference that they sponsored. They convinced Ross that they should talk about emergency medical services for children, including trauma and illness. This was published as a symposium. And then soon after, the Institute of Medicine decided that they would take it on as a topic. And there were 18 people on the panel, including these 3 pediatric surgeons. One was Dr. Haller, one was Joe Tepass, who was one of the people who started the National Pediatric Trauma Registry, and he developed the Pediatric Trauma Score, and Marty Eichelberger, who, as I mentioned, was responsible for starting the National Safe Kids campaign. So these three pediatric surgeons were part of the group that published the Emergency Medical Services for Children compendium through the Institute of Medicine, still available, and they published it in 1993. And this program finally took off about 5 to 10 years later. But as designed, it is a program that is meant to reduce childhood death and disability due to severe illness or injury and enhance the pediatric capability of existing emergency care systems designed for adults. So you heard that I've been involved in EMSC for children in Kentucky since 2004. That was something that I started with was a tri-state initiative in Appalachia. Ohio, West Virginia, and Kentucky agreed to look at the rural hospital systems in Appalachia and see what we could do to improve the emergency care. So we would go to rural hospitals and meet with a group of people and do a pin in the map study where we would say, okay, if a 3-year-old was choking in this restaurant, how would you get this patient to a hospital? Which hospital would you take the patient to? And what would you do emergently to help take care of this child? And it was a time when the system was really rudimentary. I will say that we're better than that now, but ultimately each state was funded for EMS for children. And what it has given me as a perspective is what a rural state looks like in terms of emergency care for children, both at the EMS level and the emergency department level, so that I really understand Kentucky and its rural hospitals and what we need to do to advance pediatric care in those sites. Another symposium of sorts was the Future of Emergency Care in the United States Health System. This was conducted between 2004 and 2006. There were 4 groups. One was for exclusively for children. I happened to be appointed to that committee. Bill Schwab was appointed to the one for emergency care, and then Brent Eastman for emergency medical services. So what we did over a period of a year was study the system of care in the United States for emergencies from the ED perspective and the EMS perspective, and come up with recommendations based on what we saw. In terms of children, it was a very uneven pattern of care across the United States. Most people did not understand what child abuse was, and many children were dying of child abuse. Most emergency departments did not have the appropriate equipment to take care of children. And so what it did for us is provide an impetus to improve pediatric readiness across the country in emergency departments. So when you think about what children die from, that is not what brings children to the emergency department. The number one cause of hospitalization, less than 10 years, is respiratory. And the second cause right now is depression and suicide. And unfortunately, we do not have good mental health capacity for the teenagers that we see. And on the right, you see a graph that shows how in the top graph during the pandemic, the depression and suicide rate went up in teens mainly just because of seclusion and inability to get out with their peers. So where do children seek care for emergencies? There are about 65 million children in the country, and almost half of them will seek emergency care annually. And most of them seek care where they live. So if they live in rural America, they will go to the nearest hospital. And that nearest hospital often is not well equipped to take care of their needs, whether it's a serious injury or a serious illness, or sometimes even a minor burn, because individuals who practice there are not well equipped to take care of children. This is a complicated slide. Let me break it down for you a little bit. So in the lower left are all the hospitals in the United States. There are about 5,200 hospitals with emergency departments open for business 24/7, 365. Not all of them are staffed by doctors. 1 in 13 are staffed by an APP, which is a PA or a nurse practitioner. On the upper left are the number of burn centers in this country. The American Burn Association lists about 135, nearly 80 are verified. Not all of those centers take care of children. On the upper right are the upper level pediatric trauma centers. So those are children's hospitals generally that have passed a verification process, either by their state or the American College of Surgeons, to take care of children who are victims of trauma. In the middle are all of the level 1 and 2 high-level adult and pediatric trauma centers. So there are about 184 pediatric trauma centers, and together with adult and peds, there are about 766 high-level trauma centers in this country. There are also level 3 and 4 adult and pediatric trauma centers that are usually centers that stabilize and transfer the patients, and they may or may not have a pediatric-ready emergency department. So when you think about where the trauma centers are relative to where people live, there are a lot of places where burn care or trauma care for children is not appropriate. Pediatric readiness is ensuring that every EMS agency and emergency department has the pediatric specific champions, competencies, policies, et cetera, to take care of a child. On the right, you see all the different buckets that go into a scoring system. To be pediatric ready, the top score is 100. And to be able to recognize the mortality benefit from pediatric readiness, you have to have a score of about 93, which is a pretty high score. We've done 3 assessments historically. The first one was in 2003 before the IOM report. It was only taken by 1,489 hospitals. It was done on paper, and the average score across the country was 55. In 2013, there was a very good subscription to it. Over 4,000 hospitals out of the 5,200 in the country took the survey, and the average score in the country was 69. I will say that Maryland does very well. You have probably the highest score in the nation. So you have a very good EMS and trauma system in Maryland. In 2021, which was just after the pandemic was coming down, the response rate was not quite as good, and the average score was 70. So we made no progress in 10 years. And so this is one of the places where we're really trying to impress on hospitals that they need to rise to the occasion and at least provide better emergency care in their emergency departments. There is a partnership between the American College of Emergency Physicians, the American Academy of Pediatrics, the Emergency Nurses Association, and now the American College of Surgeons to try to improve this pediatric care in emergency departments across the country. So the last segment I wanted to talk about is pediatric trauma system development, because this was something that Dr. Haller was really intent on making better. I will tell you that we do not have a trauma system in this country yet. Each state is different. Some states do better than others. I'm going to tell you a little bit about the high points and the low points. So pediatric trauma system development, the first paper that I found was in 1998. That was when trauma systems were really starting across the country. It was a concept that people were embracing. And this was a conference in Skamania, Washington, that was organized by Dr. Richard Mullins. My friend Frida Hulka was doing a research year. And basically, she compared Oregon, which had a trauma system, and Washington State, which did not at that time, and found that seriously injured children had a reduced risk of death in Oregon where there was a trauma system. So this was the first paper that I could find on that. And the next series of slides, I'm just going to compare what Dr. Haller said in his report and what happens now. just to show you that things do change, we do learn, and we try to make things better. So in terms of airway, they were subscribing to early endotracheal intubation. We now know that it's probably safer and better for a child, especially a small child, to do bag valve mask and a supraglottic airway if you can't get that, because of the fact that many individuals intubate with a tube that's too large and they can injure the airway. For breathing, especially with a brain injury, they were promoting hyperventilation, like breathing a lot, and now we know that that's not a good plan. For vascular access, they were still doing cut downs, and now we do intraosseous lines. For Glasgow Coma Scale score, there was no pediatric Glasgow Coma Scale score, and that's been developed. And for exposure, if you've ever witnessed a trauma or taken care of a trauma patient, usually they take off all your clothes and you're exposed there while they're doing the primary and secondary surveys, which in a little child is going to cause a significant hypothermia risk. So we know that we need to cover them up and keep them warm. For solid organ injury, interestingly, at that point in time, we were promoting operation and repair of the spleen called splenography. And now we are promoting non-operative management, and pediatric surgeons were the leaders in understanding that children with blunt trauma and solid organ injuries could often be managed expectantly. There was the golden hour. Dr. Haller talked about a platinum half hour, which I've never heard about, so I don't think that took a lot of traction. But we do know about the lethal triangle, and that children are also susceptible to that, and that we need to pay attention to making sure that we resuscitate them appropriately in the first hour after injury. ATLS, there were no pediatric partners at that point, which Dr. Haller noted probably led to this plethora of other courses that our colleagues in emergency medicine and other disciplines started, because they were not partners with us in ATLS, even though they helped to take care of the patients. So now we're promoting team-based care. And then for solid organ injury, non-operative management doesn't mean that the surgeon is not involved. And so the rhetoric is really non-operative management is not non-surgical management. The patient must still be managed by a surgeon. So the Health Resources and Services Administration has funded several programs for children's care, including EMS for children, which we've talked about. They now have an Innovation and Improvement Center that has a number of resources for hospitals across the country. And the Pediatric Pandemic Network is now in its 5th year of funding, and that is a hub and spoke model to help develop a preparedness model across the country. But of course, the infrastructure is pediatric readiness. So if hospitals aren't pediatric ready every day, they won't be ready in a disaster to take care of a child. So the premise is we have to improve that. And this is what the EIIC website looks like. And down there, I've circled PEAK because there are a number of trauma resources there that individuals can access. The Pandemic Network, I have a hub hospital in Kentucky. There are 13 hub hospitals. Every HRSA region has one now. There are also ASPR Centers of Excellence for Pediatric Preparedness in the country. There are 4 of those. As we develop these, the function of the Pediatric Pandemic Network is to bring emergency management excellence to the pediatric community, to build that model. And the Centers of Excellence bring pediatric excellence to the emergency management community. And what this has helped me understand is how little I knew about state structure in terms of who comes together in a disaster, how they operate, what the HPP program is, so the Hospital Preparedness Program, and all of the individuals who come together to plan, to do disaster planning, and to make sure that everything happens at the right time in the right place. Having said that, pediatrics hasn't been a big part of that. And so our job in the Pediatric Pandemic Network and the Centers of Excellence is to make sure that states incorporate disaster planning, pediatric disaster planning in the state structure. And so children must be included in state emergency management and hospital preparedness plans. If the state has a drill, it should include children. EMS needs to understand where to take children if there's a disaster, and they have to be included in their own disaster readiness plans. So what happens during a surge? A surge means, in a disaster means you have an overwhelming number of patients that need to be cared for. And in pediatrics, most of those surges are respiratory. So in respiratory virus seasons, we are often boarding patients in the emergency department because we don't have enough beds for them. If we were to have another disaster, a tornado, a hurricane, a nuclear war, we wouldn't have anywhere to put the patients. And so the surge process, understanding that, helps you load balance patients. So you might discharge patients who could be discharged. You might move patients who are less acute to a rural hospital where they could take care of them. So you create beds for patients who really need them. And there is a concept now that's being discussed as part of this military-civilian integration called medical operations coordinating cells, which are communication centers to try to help place patients in states. And you may hear about this in the coming year because this is a major program in the country that's being touted by trauma and emergency management and emergency medical services to try to help us get prepared for a potential war. I say that not to scare you, but if you've been reading the news, you probably don't live in a void and you know that this is a possibility. I just have a few more slides. I couldn't decide which one of these to use, but the Atlantic featured RFK Jr. this year on the front cover of their magazine and called him the most powerful man in science. And if any of you were looking at the news yesterday, you probably saw that the American Academy of Pediatrics lost their funding from HHS for a number of pediatric programs that really sustain children's needs in the country, and retribution for having sued RFK over his immunization practices. So this is not a happy time. And if you read the paper, you probably know that there are measles epidemics in states all over the country. And it's not a pretty time right now for pandemics, which can include infectious disease. Some of the things I've been doing include looking at trauma system development across the country. I was funded by the Childress Trauma Institute in North Carolina to do a project to do a state-by-state survey. And we looked at all of these different domains and developed a score that relates to mortality. We are in the process of doing a second version of that funded by HHS right now. Caroline Stevens wrote a paper that helped provide a blueprint for states who want to improve their state system of trauma care. This is Katie Flynn O'Brien, who just helped first author a series of papers that were published in Pediatrics, the Journal of Trauma, and the Journal of Trauma Nursing, all individual disciplines that have a vested interest in trauma care that looks specifically at system-based care of the injured child. But we still have access to care problems. And so this is Aaron Jensen. He did a study looking at how long it would take to get a child to a pediatric-ready trauma center. So he was able to get the scores from trauma centers all over the country, level 1, 2, and 3. And on this slide in the lower right, remembering that a pediatric-ready emergency department has a score of 93 or above, those are the places that are ready. And if all of the trauma centers that were high level in the country had a score of 94 or above, it would look like the map on the upper left. So it's a reach, but we can do it. And really, that's what the map needs to look like. This is the burn system of care right now. It is also siloed. On the upper map, you see all of the ABA verified pediatric burn centers. And on the lower right, you see all of the children's hospitals in the country that take care of burns that aren't ABA verified. And they don't really communicate with each other at this point. So we don't have a true system of care. And sadly, these are the rehab centers in the country. So if a child needs rehabilitation for trauma or burn care, these are the places they can seek care. And there are some places, some states that have no rehab care. Most Medicaid and S-CHIP plans, which may no longer be in existence soon, don't allow you to cross state borders. So there are a lot of children who need rehab care who can't access that care. So this is advocacy. The National Trauma and Emergency Preparedness System is presenting this to Congress, hoping to get it funded. The current report, unfortunately, lists children only 3 times and burns twice. We're trying to get that changed in version 3. And these are some of the gaps. So not every state has pediatric representation on its trauma advisory board. Not every state explicitly even mentions children in their state statute. And this is a graph that shows trauma funding by state. So about 60% to 70% of states have minimal to no funding for their trauma system of care, which exemplifies why we're struggling. The other thing is that we do in this country have a lot of teenagers, and sometimes even less than 18 having children. Child abuse is a real problem. Most centers feel that they do address child abuse with some kind of education. Most states do. They have child fatality review boards. However, only pediatric trauma centers are required to have a child abuse screening tool. Adult trauma centers are not required to have that. So again, it's a big gap. And then this looks at radiation. And so when a child presents to a rural hospital, it is not uncommon for the hospital to put them in the CT scanner and image them from head to toe, which is a lot of radiation. It's associated with a future risk of cancer. And so once again, something that we're trying to address in the future in terms of education. So we've made progress, but we've also suffered from decisions that will take a while to recover from. Inevitably, history repeats itself, and sometimes not in a kind way. So Dr. Haller ended his talk by saying, "I will end by emphasizing that surgeons are grown children. They must offer mature leadership for EMS. They must lead in the tonal management of this disease." I think he would be grateful and pleased that there are many pediatric surgeons who have taken up the gauntlet, are interested in pediatric trauma. We have a new organization called the Pediatric Trauma Society. And a few of us are interested in system development. We still have a long way to go. And I think he would be disappointed in some of the things that are going on in the country right now, because we've backslid a bit and it may take us a long time to recover from that. He was a visionary. I am grateful to have been able to give this lectureship. I know that there are those among my colleagues who will continue to move this forward. Thank you for your time.
We probably have time for some questions. Mark or Lisa, put you on the spot. That's okay. Well, Dr. Fallat, thank you for just an incredible lecture, and not just incredibly informational and inspiring, but you honored Dr. Haller throughout it, and that was masterful.